Good afternoon, everybody. Welcome to this webinar of the PSCAP. And I'm very happy and proud of the PSCAP that the COVID pandemic has not stopped us to do what we need to do. We have to reach people, especially at times like this, as you will see in this lecture. Uh, and so I appreciate the efforts of the officers of PSCAP in putting together this webinar series. This is just the start, and we want to start by viewing how are we going to shape the future of child and adolescent psychiatry in the new normal. Now, we speak of the new normal, but in truth, we don't know what that's going to be like. The new normal we know is what we have now. We are in the midst of the COVID pandemic, and there's a lot of emotional, psychological reactions. We know that our patients are increasing in number, and we will see more of that as I go on with this lecture. And we are doing this kind of media presentation. We use a lot of new platforms, and this is part of what is normal at this point. What is going to be like when the pandemic is over, and we all hope and pray that it will end soon. We don't know what that new normal will be. We will see what it is like, and we will all make our adaptations. So for today, shaping the future of child and adolescent psychiatry in the new normal. The WHO declared on March 11, 2020, that the infection going on around the world that evidently started in Wuhan, China, had gone to 114 countries and had caused infection in 118,000 cases and the loss of 4,291 people. It was big enough and rapid enough to be characterized by WHO as a pandemic. And a reminder to all of us that pandemic is not a word to be used lightly or carelessly. This is a new phenomenon, unprecedented. We have never seen anything like this before. The coronavirus is familiar to us in the form of the SARS and the MERS, but this new virus, which eventually got the name of COVID-19, is an entirely new virus. So we don't know what the enemy is like. And all our scientists all over the world are making efforts to know it better and prepare our own armamentarium. I say armamentarium because it's beginning to look like a global war. I think that's one of the perspective that we have to keep, that there is a war going on. We have an invisible enemy. We don't see destructions of buildings, but we see the casualty. We see the high morbidity and mortality. And because everything is so uncertain, we don't know what the enemy looks like, and we don't know when this is going to end. There is understandably an elevated rate of mental health issues in the community, and we learn a little bit more about that. So the coronavirus, unprecedented challenge in our lifetimes. Very quickly we realized that it's a major threat to health, not only physical health, but also to mental health. But also very quickly we realized that it also presents as a danger to global economy, affecting people's lives, influencing their everyday behavior, causing feelings of panic, anxiety, depression, and often triggering intense dread. That's understandable because as the economy started to slide down, economic insecurity set in almost in every home. Many people became incomeless, no income, or reduced income. All companies are also suffering. Every household seems to be suffering from this economic downfall. So, but in all of this, as people, as a group concerned with the mental health of children and youth, we are concerned about the impact of this pandemic in the mental health of our children and adolescents. So there are three concerns. What are the key mental health challenges for children and young people? during the coronavirus pandemic? Are there any particular vulnerable groups? What might help children and young people to manage these challenges? To understand that, we have to understand what a pandemic is like. A pandemic has three phases: the beginning or the preparation phase, and then it goes, then the incidence, the prevalence peaks into a steep curve, and then there's a slowing down and a slow return to normal. If epidemiologic measures are followed strictly, for containment and mitigation, like social distancing, personal hygiene. If we follow these measures that we know we need to do, then there is a quick flattening of the curve, as you can see in the green curve. But this is now leading into the third phase. The second phase is the peak. The third phase is when we slowly go back to normal, whatever that is going to be like. Mhm. Now, there are different mental health risks for children and adolescents at different phases. In phase 1 and 2, for example, the risks are community related, the risk to mental health. Disruptions, for example, of basic services, primarily, very importantly, the closures of school, the lack of access to basic mental health services. I think all of us closed our clinics. We had to stay home. And so we became inaccessible physically to many of our patients. In certain areas where there are child welfare services, these services became limited. And because there's no school, children are not allowed to go out. The activities, the normal activities of learning in school and socializing with friends and sharing laughters after school hours, walk in the mall, all of these are gone. And the limited leisure time activities and social relationship is limited to the closest family members. And understandably, that creates challenges within the family. Imagine your children 24/7 with you, and parents are now also forced to work from home. So this is 24/7 of togetherness. It is an opportunity for bonding. But because of the nature of the warfare going on, there is a lot of tension in all the parties in the family. Parents are stressed, children are stressed. The challenge is how to reorganize the family so that they can cope better with the stress of quarantine, social distancing, shifting homeschooling, and parents increasingly pressured from work from home. In some instances, grief and mourning for lost family members become complicated because we know that we're not even allowed to visit our family members who are confined because of COVID, and we're not even allowed to attend the last rituals and ceremonies of saying goodbye. So there's a lot of complicated grief. There we talk about the economic implications, unemployment, income decline, unmanageable debts. At the end of the month, you get your bill, your credit card, and you don't have enough money because there is no income coming in or substantially decreased income. Understandably, this will be associated with increased rates of mental disorders, substance-related disorders, self-harming behavior, and suicidal behavior. Domestic violence has become elevated, and there are reasons for that. The stresses that we have mentioned earlier: income loss, economic hardship, decreased freedom of everybody stays home, high stress rates because of this, and increased exposure to perpetrators, with the children having very little chance of a temporary escape. Now, we know that the potential long-term consequences of mental health is very much recognized and recorded when they get exposed to domestic violence. The domestic violence will include not only the children themselves being abused in different ways, but also being witness to the violence between their parents. So, the key mental health challenges for children and young people during this coronavirus pandemic, we're just beginning to know this. The full mental health impact of lockdown measures for children and young people is not yet known. We don't know what it's going to be like. There are no researches in the past that would guide us because this is an entirely new phenomenon. And the researches are just now happening. And thank goodness we have some that we can refer to. The current research now suggests that children and young people are experiencing anxiety, fear, and stress as direct or indirect result of the pandemic. We know that now. There is evidence for that in the research going on. A research in Australia, this is the UNICEF Australia, checking the ability of young people to cope, what happened to this ability to cope, uniformly showed that there is a fast decline in the ability of children to cope, whether it's in the city or outside the city, whether it's male or female, it follows exactly the same trend of downward ability to cope. Measures of young people's everyday adaptation uh, had also been shown to have been negatively affected. There is reduction in social connectedness, negative impact on the general day-to-day functioning, increasing levels of stress, reduction in levels of hope. There is evidence to that now. A Chinese study on the PHQ-9 symptoms endorsed all the symptoms. This involved, I think, more than 1,000 uh, young people aged 13 to 18. And when they were given the PHQ-9, which we are all familiar with, all the symptoms are endorsed, suggesting high rates of depression, if not clinical depression, at least depressive trends, and when they did the same thing for anxiety, all the measures of the GAD symptom checklist, rating scale were also endorsed. So there is a high level of depression and anxiety among the children, among the young people, uh, 13 and above. We don't know. I'm sure the younger ones, those in preteens, are also experiencing the same levels of anxiety. A major event that happened was the closure of school. The usual activities associated with school, which help the children adapt to their everyday life, is no more. This picture shows us that all over the globe, the schools were closed. Some were countrywide, others were localized, depending on regions. I think in our case, it was a countrywide closure of schools. So the impact of disrupted education in mental health, well, there's a disruption in the lives of students and their families who are now tasked with homeschooling as well as childcare, and the lack of access to the resources children and young people usually have through schools have impacted on their mental health. These are figures, our local figures. We have 28,451,212 students who were suddenly out of school. So we can see how much of them, 28 million children and adolescents affected, suffering from varying degrees of anxiety and depression. People are now talking about going back to school, but it's a still debate. We don't know when that's going to happen. There are plans for August or September. There are plans for online or hybrid type. So we don't know what's going to happen yet. But the impact of disrupted education on mental health includes the following: missed academic and extracurricular milestones. One of the greatest worries of the students is they might be retained, they might repeat a grade because they did not finish the year. Difficulties with transitioning to distance learning and adjustment to no school settings. The reduction in motivation towards studies. I've had patients who say, I don't know why, I just don't feel like doing my work, you know. Maybe the absence of, you know, the exciting stimulation from fellow students when they're working together or having fun together have reduced their capacity for enjoyment, and therefore motivation goes down. There is increased pressure to learn independently. The usual everyday routine is now gone, and it's a big challenge as to what the children need to do. So potentially, there are higher rates of dropout. Already, the Department of Education had said that 25% of children are not enrolling this year. That's a big dropout. 25% of 28 million is a big group of children who may not be going to school this coming year. So, we're anticipating moving to the third phase. We know that we are a long way to that normality. We don't know when that is going to happen. We all pray and hope that this will be over soon. But one thing we know is that the mental health symptoms will outlast the acute phase of the pandemic. And therefore, for all of us involved in the mental health care of young people, we can anticipate a surge of mental health problems when we get back to whatever is normal when the pandemic is over. We need to identify the high-risk children, those who were exposed to maltreatment and domestic violence. We know from many studies called the ACE, Felitti and his group in the Kaiser Permanente hospital system did longitudinal studies on experience of abuse in childhood and the implication on mental health and physical health uh, later when they grow up to become adults. And his studies uniformly showed that people who suffer abuse in childhood develop a lot of burden of mental health and physical illnesses as they grow older. Another group of high-risk children are those who have existing mental health problems. Many of our own patients that we don't get to see until we decided to use teleconferencing. The severity and outcome would worsen because of lack of access to mental health services. And also the delay in properly recognizing a rise in their mental health problem. And for the parents who are already distressed to take care of children with mental health, that's a big burden and therefore may add to the distress of the children who already have existing mental health problems. This is a study, I think this is the one done in London, where young people, 13 to 18 years old, about 2,000 of them or more, were checked as to the challenges existing with their mental health conditions. 83% of the young respondents agreed that the pandemic worsened their pre-existing mental health conditions because of the school closures, the loss of routine, and the restricted social connections. Young people have accepted overwhelmingly the response that the community had to do. Social distancing, personal hygiene, but the impact of the crisis is not lessened by this. There is increased anxiety, sleep problems, panic attacks, increased urges to self-harm among those who already self-harm. I had a patient who had to be brought to the emergency room because he did the biggest cut that he had ever done. Fixation on personal hygiene. Those who have some issues about OC become more severely obsessive compulsive. The loss of routine. Routine is a very important coping mechanism for children. They organize our daily lives, you know, when we know what we need to do at certain times of the days and when to rest and wake up. When this is gone, we sit around and overthink. And many children know this. They overthink and they think of negative thoughts and very likely negative coping strategies like self-harming activities. Young people, including those with eating disorders, had expressed in this study anxiety even about food in the midst of food shortages. Now, this continues to be a big problem, the loss of social connection, the concern of young people about losing their connection with friends. Uh, there are those who hesitate to use their phones. Maybe there are very few Filipinos who would be hesitant to use their phones. But everybody would say, at least this was documented in this study, that the physical proximity of friends uh, is and felt that talking online was not the same. They missed the physical proximity of their friends. And talking online is not quite the same. And we who have done also our own share of teleconferencing, telepsychiatry, we know that there's a difference. Well, we'll see more about that. So, what about the child and adolescent psychiatrists? What were the challenges to us? We all essentially disappeared into our homes when the pandemic was declared and the social and the uh, when we were all quarantined by an order of enhanced community quarantine. But we needed to help parents and patients. We needed to help parents how to talk to children and adolescents about the risks and the changes in their daily life, how to manage their daily life, how to ensure regular psychotherapeutic and psychiatric treatment and crisis intervention. Those of us who were able to join the Yakapap, I was very much impressed with the quickness with which the South Koreans were able to respond to this. In phase one, they were ready to come up with pamphlets, little books, explaining to children what pandemic is all about, suggesting steps on how one can protect oneself from the effect of the pandemic. There are even storybooks. Our own Joy Malinit has a lot of stories to share, but they are still yet to come out, some of them. And I think we should make all of this available to families as they sit with their children during storytelling time to help them cope with the effect of the pandemic. Mhm. So, all the child and adolescent psychiatry societies in the world were activated. We are active. We are now participating by having this series of webinars because we need to support the continuity of care to guide parents, teachers, children, health professionals on how to handle the mental issues and to advocate national authorities on the biopsychosocial impact of crisis. In phase three, anticipating phase three, we need to quickly reorganize and reestablish the lost treatment of our patients. We need to develop strategies to deal with the burden and strain of new patients that we have not seen yet and not referred because of the pandemic. We're getting them now as we instituted. Many of us are doing our teleconsult, telepsychiatry, and we know that there are increasing requests for our services through various platforms of telepsychiatry. We'll talk a little bit more of that later. Mhm. Now, child and adolescent psychiatry is in a very special position to respond to the growing public health challenges associated with mental disorders arising early in life. That's what we were prepared to do, to see young people as mental health disorders, mental health problems arise so that hopefully we can reverse them, minimize them, and avoid high intensive treatment later on. Unfortunately, this is one of the biggest challenges to us that we face. Worldwide, there are very few child and adolescent psychiatrists. In high-income countries, the number of child and adolescent psychiatrists is 1 to 100,000 children and youth, which is far from what is ideal. And the problem is even compounded in the low and middle income countries. The ratio is zero point 0.1 per 100,000 children. Child and adolescent psychiatrists historically are the mainstay of child and adolescent mental health services. So there is a big irony that when there is an increase in the demand for our services, there is not enough of us to respond to the demand. So, in meetings of international child and adolescent associations, like the World Psychiatric Association section on child psychiatry, the YACAPAP, International Association of Child Psychiatrists and Allied Profession, the World Association of Infant Mental Health, and other uh, mental health associations working with young people, were meeting and identified 4 priorities for our next phase. One, of course, is to increase the workforce necessary for providing care. Now, we all know that, and we're still struggling with that. A very important one is the reorienting of child and adolescent mental health services to be more responsive to a broader public health needs, which means we probably need to step out of our clinics. We cannot just keep practicing and waiting for our patients in our clinics because there is so much out there asking for our services. Given the time we have, I'll probably be able to share with you the first two. The last two, increasing research and research training, increasing efforts in advocacy. I think we're doing that, and we need to simply scale it up. Now, why is there a shortage in child and adolescent psychiatry? Lack of training opportunities is one of them. In our country, we now have 3 training centers. We need more. I hope we can open more to serve 47 million uh, young people. We have a population of over a million people, and 47% of that is 24 years old and below. So we have 47 million at least young people. And if we go by the observation research of WHO, that says 10 to 20% of young people in the world suffer from some kind of mental health disorder. And that was even before this pandemic. You can imagine if we just take 10% of 47 million, we have 4.7 million people who are potentially suffering from some mental health disorder. The WHO also had come up with the finding that only 20% of these people who are in need of help are actually getting some help. So there is a big demand for us, to grow our discipline. We need to overcome these challenges, lack of training opportunities, inadequate financial compensation, which I think inhibit many potentially young people who are interested to go into child psychiatry, the time necessary for training, the low professional and social status. This is not quite true anymore. I think we have gone to the limelight. The children and adolescents has brought mental health into the center stage. And now there is a call for us, including psychologists and child neurologists and pediatricians, to be involved in the mental health care of our children. The stigma of mental illness is still there, but this is probably the best we have been. It was worse when I was in training and when I was starting to practice. Some of my patients would ask to be seen at night so that they will not be seen entering my clinic. We have gone past that. Now we're getting even walk-in patients looking for us. Increased workforce training must include not only child psychiatrists, but psychologists, pediatricians, social workers, general psychiatrists, nurses, primary care practitioners, adult health professionals. What does this mean? We need a collaborative framework of working, and this is what we are moving into. Make mental health care of children and adolescents be more attractive, ensure the expansion of training positions, provide financial remuneration for child and adolescent mental health professionals, equip the child and adolescent psychiatrists of the future with different set of skills. This has implications in our training. I think we need to move more and more into training our child psychiatrists to become more adept at collaborative work. We're doing this now, and I will share some of the instances on how we're doing this. We need to take advantage of our digital health interventions. There is a body, an increasing body of evidence that support the use of computer and internet, and we will see that. Telepsychiatry, there are guidelines already in 2008 put out by the American Academy of Child and Adolescent Psychiatry and repeated, updated in 2017. These are available in the internet. There is now emerging evidence for the benefits of telepsychiatry. Some people say it's comparable and sometimes maybe even better in terms of treating those who are out of reach from the usual standard ways of treating them in our clinic. There's a special mention of children's ADHD telemental health treatment study, which showed the effective treatment of ADHD in youth belonging to underserved communities. The telepsychiatry will allow us a bigger reach. Those that we cannot reach in the past will be able to reach now through the use of telepsychiatry. Now, going back to reorienting our mental health services, there is a growing demand and diminishing resources. This is going to be a struggle. So we need a change in paradigm, optimizing the use of existing resources, working with primary healthcare workers. We have mentioned them, allowing specialists, more specialists to see the more critical and complex cases. Uh, Many of us have to see some cases that maybe some psychologists will deal with so that we can reserve our time for those who are more critically ill and need hospitalizations. We need to finance public health and prevention approaches. That's a big order for this government. We need to foster healthy child and adolescent development, and support parent is a way to fostering healthy child and adolescent development and a way of providing early preventive interventions. Support parent. I'm very happy to take note that two of our graduates last year did as their program. Now we require all child and adolescent fellows to make the research and create programs. And two of our graduate last year, Kit Diaz in UPPGH, Abigail Laganao in Medical City, made us programs working with parents, enhancing the ability of parents to become more effective parents. Abigail Laganao's program is now being implemented in Medical City, about to be launched, except that the pandemic intervened. And I'm sure kids' work can be applied also as a program in UPPGH and in other centers. So we have a shift in paradigm from direct service to consultative and collaborative work. Uh, and in the Philippines, we have had these experiences, the PSCAP partnership with the Philippine Pediatric Society. We created the mental health task force consisting of child and adolescent psychiatrists and pediatricians in an effort to address the alarming increase in anxiety, depression, suicidal behavior in young people, the pediatricians being the gatekeepers of children's health need to be helped simply to recognize mental health as part of their general health agenda and be equipped with some knowledge and skills on early interventions that they can do within their capacity with a friendly child psychiatrist available on call. We also have a model of a school consultation. There's a memorandum of agreement between the child psychiatry section of the medical city and a big university system in Manila. This is ongoing even with the COVID pandemic. We have a 12-month agreement with them on teaching learning activities that include lectures, workshops, and monthly mental health consultation. And on the drawing board, we have already the PSCAP Child Psychiatry Partnership, the Mental Health Task Force, had completed the manual for working with counselors in the school. And the PSCAP had already initiated seminar workshops for adult psychiatrists, helping adult psychiatrists in the diagnosis and treatment of child and adolescent psychiatric disorders, especially in areas where there are no child and adolescent psychiatrists. The child and adolescent psychiatrists will be available on telephone or online consultations. So in conclusion, there is a big discrepancy between supply and demand. We are faced with expanding mental health issues and disorders in children, and therefore we need the new systems of care and the paradigm shift that I was talking about. And let us take note that we have major opportunities at this point in time. The Mental Health Act was approved. We have now a law that can help guide our activities and hopefully get better support from our government. Never in the history of child and adolescent psychiatry have we had this current knowledge and skills in diagnosis, psychotherapeutic modalities, psychopharmacology, all informed by the growth in neuroscience. And parallel to this is an increasing awareness of mental health issues in the public and private sectors. All we need to do is to pull our act together, no matter how difficult it is. We need to respond to this call for help for the mental health issues of children and adolescents coming from public and private sectors. With that, these are the references, and thank you very much for listening. Daryl, exit na ako.